Dr. Ami Bhatt, Chief Innovation Officer, American College of Cardiology, advisor to FDA, a cardiologist, a educator, and inventor. So thankful to have you on our podcast here, Executive Uninterrupted. Welcome to the show.
Thank you for having me. This is great.
Ami, we've met, I believe, maybe 6-7 months ago in beautiful Boston, Massachusetts, actually Cambridge. We were in Cambridge doing a little event, and I had the amazing opportunity to do a fireside chat with you at that time amongst a biotech and consulting and tech leader AI crowd. And that was fascinating. And I've just been obsessed following your journey ever since then, and very thankful to have your insights here. And with all of our conversations, we like to take a look at the leader behind the title, and that's where I'd like to start. And you've had such a fascinating background and a journey to where you are here and where you're going to go, obviously. What took you into medicine? Was there something childhood related or later in maybe before college that said, hey, I'd like to go into medicine?
It's funny when I talk to med students now and I think about how we end up where we are. The common answer oftentimes is, oh, I loved science, I liked people. And I think that's how you look at it. And for most things, it's hindsight, right? It's in hindsight that you're like, oh, this is how I ended up here. And I think for me, it has less to do with science and the human body and more to do with the fact that there's no other profession in which within minutes of meeting someone, you have this intense relationship and kind of dependency and ability to change someone's life and to be meaningful. And I think that kind of like deep dive interaction with people, that is part of my life story. It makes complete sense now knowing who I am. And so I think it was likely something about that, probably my own relationship with my pediatrician worked out of his house. And it was great because we would go in the side door. The waiting room was like one of the rooms in his house. Then they'd invite you in, and some of the bedrooms were turned into offices. And that was how I grew up in a small town in northern Jersey, and all of us had the same doctor. And that was how we practiced. And if you fast forward to my first office after years of training, we were in a 2-bedroom apartment across from Mass General Hospital. And one was the senior doctor I joined, and one bedroom was mine. And people sat in the living room and waited for me. And so I think that is really probably somehow ingrained in me and was what I saw as being a doctor. And then, yes, I love the science and I love the heart, and we can talk about all of that. But I think that might be it.
And that's the most interesting thing. I'm fortunate to hear a lot of leaders in the executive field and science field share is there was something that pulled them early on, and some, fascinatingly enough, later in life as well. Yeah. And I think it's fascinating because what you've done, and I'd like to get into a few things, what you did in telecardiology during the time of the COVID-19 pandemic in a moment, but things that you've done and you've been a part of seem to have latched onto you and grew another part of your brain that took you to American College of Cardiology and then FDA and then other policy advisement that you provide. Now, it seems like it was a natural path. That's just from an observer view, but is that so? What took you from the bridge to delivering care and medicine over into that world of digital health?
It is never a natural path for anybody who's listening. I say it as much as I can. You look at people and you say, wow, like she had it so planned out. Look at how naturally and really every step was, I guess I'll do this next, or this seems to be needed, or gosh, I'm desperate. I have to do this. And then things happen. So for me, I fell in love with this field of congenital heart disease, which is you take the normal heart. It's pretty cool, right? It's the essence of the body. It's a pump. It's electrical system. But in congenital heart disease, people are born with it a little bit jigsawed. There's something different about it. And now it says, okay, take this unique heart that is not the same heart that everybody else has, and now see how you can help this person. And I loved that. And I also loved being with my patients from when they were in high school through when they got married. There's nothing like it. So that was my field. But the reason I bring it up is those are young people. And they said, I live in Maine. I live in upstate New York near Albany. I live in Dubai. Like, I'm not coming in all the time to chat. And we have such a physician-centric model of care, right? It is different than it was when I grew up. And it was a little bit more like it when I first started, but eventually our little 2-bedroom office was no longer HIPAA secure, all that stuff, right? Like, you had to move into the big house and into the 43-room clinic, and all of a sudden it didn't feel the same. So I could understand my patients wanting to just talk to me from home, from their couch. And that's when telemedicine started for me, was really my patients were like, why? Why am I coming in to just talk to you? I had my test last week. What is this appointment about? And why can't it be done from the comfort of my own home? By the way, most of my patients were a lot more comfortable. They were listening better from their couch than from a paper blue gown in a cold room, right? So all of that was it. But it's funny, if you look at my very first TEDx talk ever, it was before COVID. It was about telemedicine. And I tell a story of how I was a little embarrassed when people would say, how can you see your patients over a screen and call that good medical care? And I knew that it was the right thing to do, but part of me wasn't exactly sure. I was one of the first people to do it. So there was some hesitation. So no, it was not a straight line that led me to telemedicine, that led me to the ACC. I wasn't sure if I was doing the right thing for a while there. And then COVID came, and it turned out that the universe had a plan and somebody needed to know how to do this. And it turns out that the person who knew how to do it was also running the outpatient clinic at Mass General for cardiology at the time, right? These things, I couldn't have planned it. I could not have planned any of this.
And rightfully so. And serendipitous all to itself. I think the way that you are able to seamlessly integrate into that model of care and help a lot of lives in need and a lot of different scenarios in terms of level of care required during that time, it was probably right on time in a lot of ways. I do want to go into a little bit of your journey from, again, right before. So one of your, I think, great TED Talks in 2023. I will ask you a little bit about this in Boston, but your fascination with delivering care through alternative means, I think, was very much ahead of your curve at the time, because MD Live, let's not forget, pre-acquisition from Cigna, was getting some interest, but it had barriers with Department of Insurance in each state and how they could allocate a service to a patient via this mechanism. What drew you to that? Was it your time in your childhood knowing that everyone had the same physician in your small town and maybe there was another way? Was there an interest that sparked you into telemedicine, exploring it early before a lot of other physicians even cared to?
Once I started doing the telemedicine simply to keep my practice afloat, simply because these people would not come to the office. Like, just be very frank about it. I don't want to make it sound more romantic than it was. I knew I had to do this. And I like technology. I like different things. So I wanted to see what it was like. And it made sense to me to bring care to the patient where they live. And it's interesting, once you start doing something and you put it out there, that's when the Echo Health company that has the EKO, the stethoscope, they came to me. They were young. They had just graduated from college. I had given a design thinking lecture at Harvard, and they came up to me and said, hey, we have this idea for a digital stethoscope. Would you be our advisor? And so I was one of the very first advisors, because I thought it was cool that people were thinking about it. Neither one were doctors, by the way. They're still not, and they have a phenomenal company. They created something great. And similarly, then other people started coming and saying, hey, can we share the images that you see at MGH with us? How do we do that? So I worked with Kathleen Galen and some really great people at Mass General to think about, how do you share images? We used to have CDs going back and forth.
Oh.
There was no upload to the cloud image share,
Wow.
right? Like, what if the CD didn't make it in the mail? What if it got scratched? Yeah. So all of those things started coming to me in a way because I did care at a distance, and I started looking for them. What else am I missing if I'm not next to a patient? And so I think that's really what drew me more to where I got in the TED Talk that you're talking about, which is, we call it the last mile of healthcare, but it's the first mile of healthcare. The first mile of healthcare is with the patient in the home, in the community where they live. So we should be able to get healthcare there. And if you fast forward now and say, Dr. Bhatt as Chief Innovation Officer at the American College of Cardiology, or in the work we do with kind of Apple Watch or Aura, Withings or Whoop or whoever it might be, that's all patient agency. That's people starting the first mile of healthcare by measuring what they can in their home and then going from there. Hey, is there something off? Now let's seek some help. Can we seek help in the community where we live? Great. If not, if I need something more, then I come to Mass General. That's the last mile, is coming into the tertiary big house center. First mile is with the patient.
And that, I feel, historically has been reversed in the healthcare delivery model that all of us have experienced. But now, through the lens of technology and a step forward, physicians like yourself enabling that technology to be more capable than just sitting on a shelf or in a cool conference. It's now really empowered to do something up front and not that last mile. So I love where you're going. And I think a theme that I'm picking up on and that I've observed in our early interactions, Ami, is your ability to not take these dramatic leaps into the future, but thoughtful steps ahead of the current curve. And I think that makes a lot of sense in terms of adoption for those that you are serving as patients, but also the appropriate mile per hour pace of learning these technologies. I thought you took that thoughtful next step in your TED Talk in 2023. The way that I looked at it was almost into superintelligence. And I was curious on your talk of collaborative intelligence at that time, and you were talking about how healthcare needs to be not just healthcare. It needs to be able to reach beyond the previous limitations of care delivery. In summation, looking back on that talk in 2023 and us being in early 2026, is there anything you would have changed or anything that you think now has significantly evolved from your talk to current state?
I think the concept behind collaborative intelligence still stands, which is a lot of people think about AI as like an assist or an augment, right? Make someone better. Yes, that's possible. But really what we realize is to make it as good as it could be, clinicians need to be involved in the development of the algorithm. They need to be free to test it and understand what works and what doesn't and know that it doesn't work out of the box. So I think that hasn't changed. We need to know that we need to collaborate with this tool. It's not like a valve, you put it in the heart and like it's supposed to work. AI, you take it from your clinic to my clinic, we're going to have to reorg some things. It's not going to be perfect. I'm going to have to be willing to play with that. So I think that collaborative intelligence concept all the way through measuring, is it really helping my patients or not, right? I think that still stands. I'll tell you what's different. And I think I may have said it in that talk, and if not, I said it in like a Forbes article that accompanied it right around the same time, which is we should understand exactly what the AI is doing. And what I am increasingly learning is I don't necessarily know how the inside of my car works, but it works and I get in it. Now, other people know, but I may not know. I've always wanted to take an auto course, by the way, even though I know we're going electric, it just seems. But having said that, I think I was under the impression that you really need to be able to understand exactly how the AI derived a certain answer. And we're in this in-between stage now where if you realistically think about what a person's social determinants or drivers of health are, right? What their wearable is saying, what their medical record says, what the research is out there about them, right? And you put all those things together. The inference made by really good computing power and AI may be something that I can't actually put my brain around because my neurons can't function like that. And so I have to trust two things. I have to trust that the input that went in, I think, is good, solid, unbiased, important, and that the output again and again shows me outcomes that matter for patients.
Yes.
Not just saving money,
Yes.
not just efficiency. It is making patients better. And so that's where I am right now in thinking about what we call kind of explainability, not in the scientific AI sense, but just to us as clinicians, is we may not understand how we got from A to B. Now, ready for this? Last week, I'm on this panel at a side meeting for the World Economic Forum in Davos. And the guy on my panel from Google DeepMind very clearly says, no, Dr. Bhatt, you should ask for causality. We can build models that show you that this is what's driving that outcome and this is the thing you need to do. And we're going to get there. So watch me here. I'm now coming full circle from saying we should be able to understand what AI is doing exactly to maybe we just need to trust the input and the output to, oh, shoot, do we really need to understand the causality? And so I say that just to say that anytime I give a talk or even I write a paper, I recognize that it's true in the moment. Those are my thoughts or interpretation in the moment. But the science just keeps changing. So I just look to surround myself by like people who I think are smarter than me and try and take that science and say, how is it actually going to make healthcare better today? It may make healthcare better someday. Those scientists are doing all that work. But for me, it's what can we take from this that right now can improve access to care for people, that can improve how much we know about medicine, that can upskill a community health worker in rural America or Ghana, doesn't matter, to provide good care. Like, how can we start to take pieces of this that we trust and make things better now? Because that's the problem that I deal with, right? I guess that's a really long answer to your question. But
I was hoping you would take me there, Ami. And I think it's fascinating the different insights you pull back from Davos. You've had some recent, I think, helpful posts for a lot of those that weren't in Switzerland this past week on what you saw and what you're taking back. And I think it's a brilliant thing for that forum to continue to pull in physician futurists like yourself. And I hope that theme continues throughout the next several years. And what's fascinating about what you do is you do comment on the here and now. And I think that's always a safe warning sticker because of the rapid speed of development with AI models and the reach of superintelligence to what application makes sense in healthcare. One tip of the spear right now that I'm hopeful for, and I believe you are as well, is what access could be. And we've had some failed experiments, maybe some progressive experiments that didn't build to where we were hoping it would go, like behavioral DTRX that was based on billing codes. And Abe and his team, CMMI and Will Gordon and other folks, have put this model together that's soon going to be launched, I guess you could formally say, in mid-2026 in the summer timeframe. And a lot of it's dependent on data pathways being unlocked. And I see the immediate challenge being payers willing to share data at the unit of a claim all the way to a whole care journey, longitudinal data, et cetera, in an ecosystem that is not billing code based, that is inherent on adoption for digital health prescription, for apps and wearables for a senior population. Cardio-kidney-metabolic is where the population is starting with in terms of reducing disease burden and also cost. And it looks great. I'm excited for it. I'm an optimist, though. I'm always glass full, overflowing, even to that extent. Do you see or disagree? Is the payers the biggest barrier in adoption to access, or is it a bigger piece of like, hey, we need real-time feed into EMRs. We need vendors to be able to come together. We need providers being willing to adopt this without fear of being burned. I'm seeing payers as the biggest challenge for this. How should I be thinking about this?
So the answer is probably all of the above to some extent. I think what the access model that CMMI is putting out and asking for applications for right now, the idea behind it is for us to be able to say, if you take the payment model out of the equation, if you pay for outcomes, will there be better uptake, either clinics and practices themselves creating remote care management platforms, or the hospitals, especially not the ones that are tertiary academic level hospital, right? The ones that actually care for the majority of Americans. Does that level of hospital now see a benefit in working with a company who has a platform that can help bring in the data, that can help say, hey, your patients at home are doing well. They're at their own baseline. Oh, wait, they're out of baseline. Let's see if we can get them back to baseline for blood pressure. If we can't, now we're going to trigger somebody. Can we start to get these kind of models up and running for the majority of Americans who get their care from places that probably don't have the ability to either build out their own models or to pay companies that need to charge in order to be able to validate their existence to do this? And I think the reason this works now is we've been barking up the efficiency and the fiscal efficiency tree with remote monitoring for quite a while. And the government is now saying, and Jacob Schiff and Will Gordon, all good friends, are saying, nope, outcomes are the outcome. We want better outcomes for our patients, and that is when you get paid. And I think that shift is going to be really important. However, yeah, maybe that'll work for Medicare, right? Like maybe that'll work in the CMMI population. Are the payers going to get on board? Well, if you can show outcomes, we hope that payers get on board. Now, what if you could argue back and say, hey, the average patient only spends 18 months with their insurer and then moves to somebody else, right? So yes, employee health may really care if you have long-term employees. So like those payers may come first. Value-based care is going to love this, right? But what I would say is cardio-kidney-metabolic disease. These are the risk factors that lead to heart attack, stroke, dialysis, the most expensive things. Early death, morbidity for families, tough time for the whole rest of the family. How do you manage when you have a patient with stroke and now dad has a stroke and he's at home? So I think what we will see is that the payers will realize this area specifically, it doesn't matter if it's my patient or your payer company's patient that is getting this kind of care. If we decrease the rates of stroke, heart attack, and kidney disease, all payers will benefit. It is expensive to them as well. And so I think this is the first time where everybody, if you really think about it, should be aligned that a program like this needs to work. Now, devil's in the details. American College of Cardiology, we are partnering with organizations, getting ready for whoever is accepted to the Access program to sit down with us so we can just think about, how are you going to unleash this on a system? What is it going to look like? What does deployment look like? What do metrics look like? How are you going to educate people that they want to be part of this program? Right? What is that? So we have to get like really boots on the ground efforts now at having this Access program be successful. And that means talking about it, thinking about it, designing it right, teaching about it. And so that's the next step for all of us.
That's probably the most exciting thing I've heard come from a conversation around Access so far. And I've talked to a few big fans of it recently, Dr. Jonathan Slotkin, Geisinger, Dr. Daniel Kraft, who you're good friends with, and many others. And you went to a level that I was hoping we would get to, which is once we have applications come in, we assess them, and we have payer adoption, we're showing outcomes. You took us through the journey of what can be for scale that is of this population that it's aimed at right now, and then beyond. And it's not just the business model, but it is truly the healthcare model, not only of the economics, but the impact, quality of life, lifespan, health span. There's so many trickle-down effects that this program could be attributed towards. And I think a lot of us are very thankful that you are a part of this, not only with ACC, but also helping CMI as well. So fascinating, very much a big fan of what this can be. So, Ami, I can't help but think the young Ami probably had different options that weren't medicine and maybe even technology or the curious scientist that you are aligned. Is there a younger version of you that would have gone down a different path that would have been maybe just research academia? Maybe there's an engineer part of your brain I feel exists. Is there a different type of career path or calling that you would have decided on that wasn't medicine at a younger age?
Yeah, this is my favorite party trick question type thing. No, it's musical theater.
Really?
I would have.
I would have been on stage singing and dancing and just happy doing that. And my poor family suffers from this because they were singing and dancing in my house ever since my girls were little. Nighttime dance parties are a tradition. All of their friends knew it when they came to sleepover. There's a creative side, I think, to every academic's brain. And that's actually, I think, what makes a lot of this so exciting is we're creating again with AI and with these new pathways. And the world is finally opening up to say, hey, do you want to do this better? Like, let's design it better. And I think that's why I love my job right now, right? It's just, do you want to design it better? Can you design it better? And maybe part of that musical theater for me is also not to call this theater, but the ability to communicate to others why you're excited about something. And I think that's a large part of what I love about what I do right now is to take the science and the structure and the governance and say, but why? Like, why does this actually matter to each of us as just like a human, a U.S. citizen? Like, why does it matter?
I think that's a rare answer I've received to this type of question in the past, Ami. But I now will think of you as a future Broadway star. You have a long continued career ahead of you. And if perhaps Dr. Stephen Klasko is any example, I believe he's a DJ these days and he still maintains the business side in healthcare. But I think it's fascinating the way that you think and how your brain truly operates in a very chaotic, difficult to navigate, sociopolitical driven healthcare economy these days. And I can speak for a lot of the rest of the ecosystem. We're all very thankful that you are a leader that is helping not only bring new innovation to application, but also encourage, inspire other leaders to take an interesting, maybe unnatural path. And I'm so thankful that we had your voice on our show here today at The Executive Uninterrupted. Dr. Ami Bhatt, thank you so much for joining us today.
Thank you for having me. I love what you're doing here.
Thank you very much. And for more insights, please visit outcomesrocketmedia.com.